It's now my pleasure to introduce you to our next speaker, Associate Professor Mark Yates, who has flown in this morning from Melbourne to be a part of today. Mark will be presenting. So, what do you want to know about dementia? Mark is currently a consultant geriatrician at Ballarat Health Services, a clinical consultant of the Cognitive Assessment and Dementia Management Service, the project head of the Cognitive Impairment Identifier Program, the Director of Clinical Studies at Deakin University, and a clinical tutor at the University of Melbourne. He is a former member of the Pharmaceutical Benefits Advisory Committee and a current member of the Minister's National Dementia Advisory Group. And in his spare time, he travels to Adelaide. With a long-standing interest in the care of older people, Mark's main areas of clinical interest are dementia and memory disorders, continence management, constipation, airways disease, and healthcare delivery in an ageing society. Please join me in welcoming Associate Professor Mark Yates.
Yes, master of all the sexy things. Yep. Thank you very much. And wow, what an audience. When Marion said there were going to be 300 people here, I sort of somewhat inappropriately, my response was OMG. But thank you very much for inviting me here and inviting me to speak. And can I just echo perhaps Kathy's comments when she stood up after hearing that beautiful story from the Glovers, how important that is. And I guess in my life in geriatrics, and particularly in the areas of memory and thinking disorders, it's been listening to stories from you that has actually taught me much more than what I've learnt in my textbooks or what I've learnt from reading journal articles, because as you can see, the research areas really haven't been that brilliant, but I think the areas of change in care and care provision is actually where we can make really substantial change. Having said that, what I'm going to try and do is to answer your questions about dementia. And I did a session like this at Port Lincoln not very long ago, and there were a nice group of 60 people, and it was really intimate, and we could get close, and I had a mic. I might try and get a roving mic for myself, because I tend to walk. I'm a bit of a wanderer. I'm sure when I'm older, I'll be a problem, because I want to take a cup of tea, and I want to walk around my garden, because that's what I do every afternoon when I get home from work. Who does that? Who does that? Come on. Yeah, we all like to do it. And yet... well, then I'd be called a wobbler. So what I want to try and do in this hour is not to leave you disappointed. In order to do that, I think I probably have to answer the questions that you've got about dementia. And... So I think that I was very lucky to follow a really great dissertation by Kathy, not only because she actually did a brilliant job at summarising what's a very complex area, but she also probably left as many questions as she did answers, because some of that stuff was pretty complicated. So I'm happy to answer any questions to clarify some of the things that Kathy talked about, but also about any other questions you had about dementia. So I want you to be brave. And... I don't know where this is. Maybe I'm pressing the... Oh no, maybe I have to switch it on. Yay. Simple, I can't use the remote control. So, meet Fossie. But I think Fossie's got that very inquisitive look. Fossie wants to know everything everything about dementia. She's one of my cows. This is in the back of my backyard at Ballarat. So I want to know from you what questions you have that you want answered today. And Julie's the scribe, because I can't remember everything you're going to say, sorry. And we're going to try and take all those questions around the room, put them together, and try and provide you with that information back. So who's going to be the first brave person off the rank and who wants to ask a question? And we're going to load them all up, and then I'll try and follow them. Yes? So we've got 2 roving mics, so put your hand up early so we can get the mic to you.
Thank you. What does the MMSE score represent, please?
Okay, that's a really good question. So what does the MMSE score represent? Another question here? Yep.
Yes, I realise dementia has a lot to do with memory loss and that sort of thing, but people keep saying also that it's a great cause of death. Can I have some understanding of what it is about dementia that then leads to an earlier cessation of life?
So I think that's about the prognosis, dementia and its prognosis, and also perhaps some questions about end of life discussion. Yep. Any other questions? Yes. Put your hand up early so we get a mic too. There's another question down here.
Just from anyone in the room, really, engaging people who have dementia in conversation. What's the best way of doing that?
Yeah, how do you have that conversation? Really good question, because it sometimes can be a bit of a monologue, can't it? And that can be quite challenging. There's another question here.
I have 2 questions, if I may.
Oh, 2 outrageous. Yes, okay.
Kathy mentioned about the pathophysiology of Alzheimer's dementia beginning 20 years prior to the actual symptoms. So what sort of screening can be done for people and who are considered at risk?
Yep.
And the second question is, given that generally the patients that we see with dementia are greater than 70 years of age, looking at the metabolism of the medications through like liver and renal, particularly looking at the anti-inflammatory drugs, which are not particularly recommended for patients with CRF, which is quite often that happens after 70 years of age.
Yes, okay, so I think there are 2 questions. One is around what was the first one? Screening? No? That's right. So that's that's about diagnosis. So we'll put that into the diagnostic group. So we'll work from diagnosis. And the other one was about really the safety of the anti-inflammatories and the other changes that happen in older age with metabolism and the impact of those medications. Yes. One over here.
I'd like to understand more about sundowning.
Sundowning, yeah, I'm very glad you've asked that question. There's a really good LinkedIn group. I don't know whether anybody else is in LinkedIn, but there's been a really big blog conversation about sundowning. So I'll talk about sundowning, and we might group that into other symptoms later in Alzheimer's, later in dementia. Yes.
My husband was diagnosed with early onset, but as we were leaving the specialist office, he mentioned frontal lobal.
Okay, so we might talk about the different sorts of dementia, because I think that might be quite useful. Okay, yes, but? Oh, 2, yep.
Does the early onset mean that that's what he has, but just in the frontal lobal, or how do we define it?
I reckon we ought to talk about what is early onset as well, as opposed to timely diagnosis. We might talk a bit about that. We've got, oh gosh, sorry, you're still going.
The length of time for frontal lobal, is it slower than early onset?
So again, that's about the prognosis of various dementias and what they look like. So we're going to talk a bit about prognosis as well as the Now there was a question there.
Aged care facilities. What's the best practice for a patient who has got dementia?
Okay.
Yeah.
Wow, Richard Fleming would be right onto that one, but I'll try and do that that would take him about a 2.5 hour talk and a tutorial, but we'll try and do that in about 1 second.
Yeah,
yep.
That's fine.
Thank you. Hello, yeah, I'd just like a quick overview in terms of early onset dementia and sort of housing opportunities, support opportunities, and
okay.
It's a broad question.
That's a sociological question, but I'll try and get something around. We'll talk a bit about early onset dementia, and I'll try and cover something about opportunities around care in that population, because that's quite a different population.
Yeah, and in particular, housing.
Housing. Okay, right.
Mark, I'd like to ask about the effectiveness of scans, and in particular, I think Kathy mentioned SPECT and FDG PET scans, and where are they available?
Right, yeah. And so that's around diagnosis. So we've now talked about causes, prognosis, diagnosis, and then we've talked about a number of other social issues. So let's take 1 or 2 more questions, and then I'll stop, and then if I've got more time, I'll follow it. Yes?
Early stage with my dad, and he's got vascular and frontal lobe stuff happening.
Mm-hmm.
He hasn't had an MRI, and the geriatrician that he's seeing is umming and ahhing about an MRI. What would I do?
Yeah, what would you do? Yeah. I can answer that one really quickly. I do an MRI. And I'll come back to why when we talk about scans. Yep. Yes.
Yes. Just wondering about a simple description of the pathophysiology and what these amyloid plaques and the tau.
Good. Lucky I brought my slide with me. Yep.
I was just going to ask, have you got any more to tell us about dementia-friendly hospitals?
Yes, I can and I will. Right at the very end, I'm glad I've been asked that. Now I don't have to bring it up myself. That's fantastic. There's one last question at the back, I think, and then I'm going to stop and try and answer questions before I forget absolutely all of them.
Can you clarify the role of the neurologist, and how quickly does a person with a diagnosis of early stage Alzheimer's need to be connected with a neurologist?
Okay, so again we talk about prognosis. So let's have a look at our bits of paper, and I'm going to start with, what does the MMSE, but cause, prognosis and diagnosis. So what I'm going to start with is something really simple, because I like us all to get on the same page, is this slide here. And this starts to talk about some of the aspects around what is the difference between dementia and Alzheimer's disease. And we're going to come and talk about this because it's really important to get the sense of what we're talking about. And I think we often confuse these two things. So can I just, before I start, just get a clear idea, how many people here are people living with dementia or someone who is a family carer of someone with dementia? Is that the majority? Okay, that's the sort of a healthy number. And those who are professional carers, another... Okay, now, a lot of you then are really interested in this, but I've forgotten, what group haven't I covered? Maybe allied health, nursing and hospital care staff and those sort of things. So quite a few. Fantastic. Okay, so some of this will be common to a lot of people, but one of the most common questions I get asked, which is along the lines we've been asked about today, is about the difference between dementia and Alzheimer's disease. There's a couple of really good YouTubes if you want to look it up. One great one done by Trinity University at Dublin. But I guess the way I describe it is that dementia is like saying trees. Okay, and Alzheimer's disease is the gum tree. So the most common tree in the bush. And there are a couple of others that are really common, and I'm going to make mention of these because they were raised. And vascular brain injury or vascular dementia would be one, and Lewy body dementia would be the other. Now, what I haven't mentioned is frontotemporal dementia. And just to answer this question about early onset and frontotemporal dementia, to get that one off the tick that one on my list, is that in fact what happens is the earlier, in younger people who develop cognitive impairment or develop a dementia, and I'm going to come back to some definitions of that, they tend to move away from Alzheimer's disease being it's still the most common, but the numbers and proportion of people with Alzheimer's disease tends to be less in younger people who develop dementia than in older people with dementia. So once you get into your 75s and 80s, by far and away the most common reason to have dementia is Alzheimer's disease, or a mixed picture with some vascular changes. Kathy mentioned, she mentioned that bit about having mini strokes and whether that set up more likely to have the symptoms of Alzheimer's disease. So in older people, so those people over the age of 75, I have to be careful, I don't think that's all that old, that's middle-aged. Nobody gets to see me until they're 65, and they're my young ones. But I do see younger people with dementia who are under the age of 65. So if you're younger and you've got a dementia, then it's more likely to be you've got a greater chance of being a frontotemporal dementia. And frontotemporal dementias, as you know, can present in very challenging ways, challenging to us as docs, because it's very difficult to pick the difference between someone who's just become more anxious or a little less organised in the way they do things, and maybe they're actually drinking a little bit more because that's just what happens, and we find that very difficult to differentiate. And I think that it's a very, very difficult and complex diagnosis to make, and it takes me time. I mean, we say that in primary care it takes about 3 years to go from first symptoms to diagnosis across the board. I think it takes longer than that in the younger people, and they say it sometimes to take up to 4 to 5 years to make a formal diagnosis. And when you think about it, it's because the diagnosis is not something, we don't have biomarkers. We can't actually say, it's not like a blood pressure. You can just take the blood pressure and say, yes, your blood pressure's 180 on 100, you've got high blood pressure. Well, how do you do that with someone with dementia? You don't know, because it's gradual in its change. And this is why I like to come back to that diagnosis. So that's the first question. Does that answer that question about the sort of frontotemporal? It's not that all early onset dementia is frontotemporal, by no means it is. It's just that there are more people who are young who develop dementia who are more likely to have frontotemporal dementia than others. And it's, again, a very variable course. So that's talking about that. So then the other... I just need your bits of paper, I think, because I want to put my head around all of those. Because there were so many questions, they came so rapidly that I couldn't remember them all, you know. There is a cognitive limit to the brain. We can really only manage about eight items, and then we can't remember any more immediately. So if you've got to mobile phone numbers and you can't remember them, don't be too distressed, because really it's very hard. That's why we all got them programmed into our phones. The prognosis of the frontal dementias we've talked about, and so then I'd want to talk about the difference in prognosis. Do people understand what I mean by prognosis? Because I'm using these ridiculous terms, I get so used to it. Prognosis is basically what happens over time. So what's the lifespan? And this comes back to this very, very important question about dying in dementia. This issue about we were having this conversation just earlier about dementia and it being a terminal illness. I think dementia is no more a terminal illness than diabetes. You know what? More people are living with dementia than they are dying with dementia. And there are as many people living with diabetes as they die with diabetes. And your prognosis, your lifespan, is limited by the fact that you have diabetes, as it is limited by the fact that you might develop a dementia. So I don't think we want to be convinced by anyone that dementia is a terminal illness. It is at a point, at some time, when we get down the line of the history and the pathway of dementia. We do know that at time it's going to result. Dementia does cause people to die earlier than we wish them to do. But many people die with a condition that's other than their dementia. So they actually live quite happily. And so some people, I mean, you could take prostate cancer in men, for instance. Most men die with their prostate cancer. They don't die from their prostate cancer. And I think we all understand that. And I think that we find many people can die with their dementia, particularly in the vascular group, sadly. Because if they've got vascular dementia, which is mini strokes, the arteries around your brain are very similar to the arteries around your heart, in your feet, around your kidneys. So if someone's got a lot of vascular damage in their brain, they're likely to have vascular damage around their heart, and sometimes they can have a heart attack which then takes them away, or they can have a stroke which takes them away. So it wasn't the dementia per se that caused them to pass away, it was actually another condition. So I think we're going to be very careful about how we talk about dementia and terminal illness. I don't think it's useful to equate those two things, because I just want you to think about this. Because I want to talk a bit about dementia, because I think this will help in our thinking about some of those other questions that we had. So dementia is really a chronic decline. It's a slow process where there's a change from previous levels of cognitive status. And we know at the moment that it can be managed, but we can't actually cure it. Most importantly, that dementia is not unitary. And it certainly doesn't indicate severity of impairment, nor does it indicate the prognosis. So, as I said, dementia is like trees. So if you say, well, I'm going to plant a tree in the garden, someone's going to say, well, what sort of tree are you going to plant there? Because it's no good planting a lemon-scented gum that's going to drop leaves on your roof. You want to plant something else like an acer or a silver birch that doesn't drop limbs on your roof. So, you've got to know what you're dealing with. And I've had this problem in that when we get to hospitals, people say, well, this person's got dementia. Well, that's not useful to me. If I said when I was a registrar, if I said to my cardiologist, oh, this man's got heart failure, he'd go, what's the cause of the heart failure? Don't tell me he's got heart failure. I want to know what it's caused by. Is it caused by heart attacks? Because he had lots of damage to his heart because he's not got a blood supply. Does he have thyroid disease? Because that makes the heart go wrong. Does he have other valvular problems? So the valves are leaking, so it's not working properly. So we have to know all these things. So dementia is not unitary. Dementia is just a sign, it's not even a diagnosis in a medical term, it's a syndrome. And it describes memory and thinking difficulties. It does no more than that. The people I diagnose in my memory clinic, which we call in Victoria CADAMS clinics, Cognitive Dementia and Memory Services, their MMSE score on average is somewhere around about 24 to 26 out of 30. They're still looking after grandkids. They're still driving their car. They're still active in the community, playing at the bowls club and sometimes secretary. It doesn't mean that they no longer belong in the community. nor do they feel impaired. And they don't feel like they've got a mental illness. They might be bothered by this memory problem, but they're not withdrawing from the community, and they need to be empowered to stay in that community. So dementia is as wide as it is as any other condition. And we don't say someone is heart failured, do we? Do we say Jack's heart failured? No, of course we don't, because we know that Jack might be one end, he might just be, I'll need to take 2 tablets of water tablets, pee for a couple of hours in the morning, and then he's off playing 18 holes of golf. Or there is Harry, his mate, who's actually in a wheelchair because he's so breathless and legs are so swollen he can't move about. But we understand that in heart failure. Does that make some sense? So why do we say someone's demented? Well, it's a pejorative term, and it boxes them. That's it. You're demented, because if we say someone's got heart failure, you say, well, how bad is it? Or how are you getting on? If you say you're heart failured, well, that's it. You're heart failured. So if you say someone's demented, it has the same pejorative term. You no longer could we are going to ask questions about how you're getting on, because that's assumed that it's all over, Red Rover. So let's talk about this term dementia and ask about what that really means. Because we need to talk about people who have dementia, and then we ask, oh yeah, well, how's he getting on? Oh, not too bad, really. Still looks after the grandkids. Had to drop his licence last year, but you know, that's the way it goes. But you know, still keeping going. So let's think about this term dementia, because it doesn't tell me the severity of the condition. It just tells me about a number of things. It first of all tells me there's a memory problem. So we have a difficulty with memory. And the memory problems, you must in the audience have heard about this, is the difference about the memory problems. What's unique about the memory problems in dementia? What happens first? What do you forget most of? Someone with dementia will be able to stick up their hand and say, I know. Short-term stuff. Yeah, we forget new stuff. Learning new stuff is hard. So that new information, which is actually pretty good. I mean, if you were in an oral society, a society that relied on language, wouldn't it be great to have the wise old man in the village who didn't have to think about what day it was, because that's irrelevant anyway, but could tell you that 20 years ago, when the smoke came from that side of the hill, it was bad news because the village got wiped out. I actually think, there's an argument that we will all have dementia by the time we're 114. And I think there is a concept that some perhaps Alzheimer's disease, we're genetically programmed to have Alzheimer's disease because in a way we wanted to keep this oral history, so we knew what was happening in the past. Our wisdom's still there, but what happens day to day is not too important really when it comes down to it. So the memory problems are all short-term memory. It's new information. Someone said, I think, asked the same question 100 times. Very frustrating. But, you know, that's the way it goes. So the memory problem is one thing, but there are 4 other areas of change that happens in dementia. And this is a very complicated language, so I'm going to try and explain it. So aphasia is problems with speaking and saying words. Apraxia is the problem with using your hands. You haven't got a stroke or anything, you haven't got nothing wrong with your arms, it's just you don't get it to go together. Agnosia is recognition. And executive function is this planning. So what does this look like? I think that there'll be people in this audience who could tell me what it's like to hear someone who's got a language problem. What do you notice?
They get frustrated.
Frustrated because they can't find a word? Yeah, it's on the tip of the tongue. And what we'll often see is that it's atypical words, so it's words we don't use very often. So the man who was an engineer and worked actually at the Bureau of Meteorology as an engineer, when I was asking him about what was happening in the news recently, and it was the time of Hurricane Katrina, he said, oh, you know, there was that big wind. Now, he would have known the word hurricane, but he wouldn't have used the word on a periodic basis throughout his life. But he couldn't find the word, but I knew exactly what he was saying. And it's like the lady in hospital who said, you know, oh, they got cross with me because I forgot those little round things. Okay, I mean, they're the pills. So this is what we call circumlution. So if you've got someone particularly with Alzheimer's disease, there's a language. The language is not, you can't say anything. Of course you can say lots of things. You've got lots of important things to say to people. It's just that it might take you longer to say it because instead of using rather complex words, you're going to use more simple words because you've lost those more complex, uncommon words. So it's often get the thing on the thing. Well, my mother said that ever since I can remember as an adolescent. I think we all say that. So that's not quite enough. But I always say the only problem, you haven't got a memory problem as long as it's when it's worse than your doctor's, so that's okay. So you're okay to come and see me, because so language is about that ability to find those complex words. So it's in the kitchen looking for the things like the sieve. Oh, I'm looking for the, where is it? And you go and get it, which is fine, and you can go and get it, so long as, and we'll go down to the bottom one, you don't have agnosia. Agnosia is a funny word, isn't it? Sort of, I think it's sort of like the nose on your face. It's as obvious as the nose on your face. And the problem with agnosia is not being able to find things. And I think this is something that's very typical of a complaint from ladies about blokes. In my family, it's called a boy's look. But it's an experience I'm sure some of you have had, where the person you care for, who has got a dementia, is looking for something and is so frustrated because they can't find it. And then you go and say, oh, duh, there it is. And it's, you don't say that, obviously, because you... My children tell me that. But you think that. Why couldn't he see that? Why did I get dragged from reading my newspaper? I was just sitting down. Or is it the hot cup of coffee and hot piece of toast? It's like anything else. Just sat down to do this. And he's calling to get something. It's right under his nose. Very, very frustrating. But in neuropsychological terms, in testing terms, what we do is we actually show people drawings of things like a set of glasses. And we take the bridge out of the drawing. So you do the drawing, but you haven't drawn the bridge. And you say to someone who's got an agnosia, what's that? And they go, oh, I don't know, it's an egg poacher, or it's a note. Because if you imagine a circle with I haven't got a whiteboard, it might look like a note. And then you say, well, no, and then you put the bridge in. Oh, it's a set of glasses. And it's this ability, what we're doing is we are mapping our memory of the item we're looking for, we're searching for it, and we're looking for a match in the environment that we're in. I'm getting lots of positives from George here. And if it's partly covered up, it's very difficult to make that match happen because you can't find it. So one of the advice I'm sure you would have had is that you might be told to make the environment less cluttered. It's really sensible advice, because then objects that are there are easily seen, and they're seen for what they are. Who's got a drawer from hell in their kitchen? The third drawer from the bottom. It's got everything in it, hasn't it? It's got the garlic crusher. And I've had this, and I think we can all have this experience and try and understand what it might be like. We have it once or twice. But to think about what it's like to have this all the time, where you're going to look for something and you're in a bit of a hurry and you can't damn well find it in this drawer from hell. And for me, it was the garlic crusher, because I was burning the onions when I wanted to get the garlic on. And I said, I can't find this garlic crusher. And my daughter goes, you did. And my wife had just bought another one. But it was a different colour. Exactly right. I mean, I'm colourblind, but that didn't make a difference. And I was looking for the other one. And it was in the drawer from hell. I was in a hurry, and I couldn't find it. And it's so frustrating. But imagine what it is like, not for something as complex as a garlic crusher, because you don't mind to think that's complex, but it is. But it's actually for day-to-day things. It's like the car keys. It's like the wallet. I'm just looking for the newspaper. But that's underneath the bowl of fruit, because the bowl of fruit got put on the newspaper, or it's under the side of the iPad. And I can't find this and I can't find that. Very, very frustrating. But that's what agnosia is. I imagine agnosia is like for someone who's got cognitive impairment, in particular dementia. And so that's my agnosia story. So what about apraxia? This is a very hard concept to get hold of, but it's actually not that difficult if you think about how we process information visually. Apraxia is the ability to do things with our hands when our hands haven't got arthritis. And I like to ask questions of my patients about whether they're still playing golf. And I do that for two reasons. One is because some people withdraw from golf because their swing has become erratic and they're really cross with themselves and they find it's very frustrating. And that's a setting of partly in the setting of apraxia. In other words, they can't no longer get the clear rhythm of what is a complex movement in golf. The other aspect of golf is that you have to keep your neighbour's score, your partner's score. It's very embarrassing when you keep getting it wrong. And unless your partner's willing to just help you out there, then in fact that can cause some friction. And we've worked quite a lot with families to say, look, just get a mate who's prepared to just do all the scoring, and it doesn't matter what Bill says the score is, but just say yes and carry on and enjoy the game, because the score's not terribly relevant. It's a pretty dull game, really. So how do we understand apraxia? What would it be like? I mean, how often do we do things where we don't watch our hands as we do it? Lots of times. Tying a tie. I see a lot of ladies when they redress after being examined. It's like, sort of, you know, they do up the bit at the front, pull it all around, tuck everything and stick their arms in. Well, you know, getting around here is pretty hard. It's pretty hard to get around all the time. And it's a really interesting dressing action. But it's true. And it's blokes don't come in. I mean, I live in Ballarat, and we've got the solid farmer type. Don't usually come and see a health professional without getting properly dressed. And there's no tie, the braces are gone, you know, the shoes aren't done up. Well, it's because often it's a damn nuisance to get those things done up because it's difficult. And the last example I'm going to give is my own. Who are the blokes in here who've ever tried to trim their eyebrows? I've got these very bushy eyebrows. In the mirror. I tell you, I've nearly poked my eye out 4 times. Because every time you try and move the scissors backwards and forwards, they move in the opposite direction. It's true, isn't it? And most ladies work this out very early on because you put on makeup. But how many people have watched a 9-year-old try and put on mum's lipstick? Where does it go? Up to ears. Because that child hasn't yet learned how to be praxic in a mirror. I haven't learned as a bloke, other than shaving, but that's a very tactile thing. I can actually follow that with my hands. I don't need the mirror. I can shave in the shower without a mirror. But to use a mirror and try and actually get my hands to move in the right direction is a praxis skill. And can you imagine where every task you do is like doing it in a mirror? So in other words, when you're looking and you've got your hand there and I want to knit, and it's like looking in the mirror all the time. So when I go this way with my brain, my hand's gone in the opposite direction. How frustrating that can be, doing up a button. And so apraxia can be very mild, but on the other hand, it can be quite disabling. And right at the very end of the praxis story, as dementia is more advanced, then walking becomes a challenge. And we need what we call motor processing. And so when we stand from a chair, when you think about it, you lean a little bit forward. You might put your hands on the arm of the chair. You tense up your legs. You push your weight forward, not too fast, so you don't fall forward. Not too far back, so you don't fall back in the chair. And this is a process of praxia. This is about how our motor processing works. And I had a lady last week who I saw at Horsham who had broken her arm. She had very severe dementia. So, I mean, her MSE score was about 10. And I couldn't get any conversation from her. We talked a little bit, but she had very severe language difficulties. But she was managing at home quite well with the support of a really caring daughter. But she fell over and broke her arm. And all of a sudden, her mobility had gone. And I was asked to see her because she was going to need residential care, but her daughter wasn't too keen on that idea. She said Mum was okay before she fell over. Why has she lost her mobility now? It was her arm she broke, not her hip. So they x-rayed her hip and nothing was changed. And I said, well, just wait. Because when I looked at her, I said, first thing I said is, how are you getting? Oh, I'm fine. Any problem with your arm? No. I said, just put your arms in the air for me. She goes, oh, that hurts. And this lady couldn't recall that she had broken her arm. So what happens when she stands? She gets a painful arm. And what's more is then the staff are saying, well, come on, we'll help you stand up. And what happens when people grab and push and hold is that it disrupts that immediate motor processing skill. So in fact, that natural movement to stand up, it gets lost. And so then people lose mobility. So 3 weeks later, and I went back to see her day before yesterday, and she's up and walking because she can do it by herself now. So I said, well, come on, we'll go and have a look out of the window. And we just went. Because she could walk when she doesn't have to think about it. When she has to think about it, it's all gone because that praxis is gone. So that's the sort of two ends of this idea of problems with praxis. And the last area is this disturbed executive thinking stuff. So what do we mean by disturbed executive, did I say executive planning? What did I call it in the end? Executive function. And that's about a really important part of our thinking. That's about where the frontal lobes come in, and that comes back a bit to the frontal lobe dementia story and about what changes happen in frontal dementias, but it happens also in Alzheimer's disease and across all the dementias, and in vascular dementia, and that was another question that was raised. In vascular dementia, you often get damage in what we call the lower part of the brain. It's called the subcortical area. I always thought that was very hard, that word subcortical, because I always imagined the core being the middle bit of the brain. But the cortex, which is what we use in the medical language, comes from the Greek, which means cloak. And it's the cloak of neurons that wraps the outside of the brain and gets all curled up so that it becomes the gyri. And so the subcortical area is all the wiring that goes between parts of those neuronal connections. And in vascular dementia, you get damage to the wiring down in the subcortical area, and there's a lot of wiring that goes from the frontal lobes into the rest of the brain. So people with vascular dementia can have quite a lot of what we call executive dysfunction. Their processing speed is slow, so they take a long time to answer a question. Their walking changes, so they're a bit slower with their walking. They can have strokes as well. So just going back to this then disturbed executive function, if you haven't got your frontal lobes, then all the things that you might think about that you don't want to say, you might actually go and say. And that's always a bit difficult because that can be very embarrassing. It can be embarrassing for the family if something like, how many times have you been walking with your grandchildren or with my children when they were 3 or 4 goes, oh, look at that man, how fat he is. Oh no, don't say that. You can't say that, Johnny. But we do. Kids do this because their frontal lobes haven't actually been wired up quite yet. And they have to learn that it's not appropriate to point at people and point out physical change or disability. And sometimes when the frontal lobes are damaged, what we think is what we say. Some people wonder about Tony Abbott. Oh, sorry. But anyway, we'll carry on. Some politicians generally, I think, I wonder sometimes whether their frontal lobes, and certainly some people on Facebook, clearly have unwired their frontal lobes. So that's a real problem because it can be embarrassing. The other thing is about the frontal lobes is that it helps us with our abstract ideation. And someone was asking about abstract thinking. It's a very complex term. It's as simple, really, as saying what's similar about an apple and a banana. They're both fruit. But if you have a concrete thinking, in other words, you can't have that abstract idea that they're both fruit, you might say, well, they've both got skin, which they have, but that's very concrete. In other words, it's what you can see in front of you, not how you can sort of abstract that idea. Another way of thinking about it is if you imagine a cube, think about a cube now, and if you hold it up in your mind, how many sides can you see at any one time, however you move it around? 3? So if you've actually got a problem that's got 6 sides, which a cube has, and someone brings you the cube and shows you 3 sides and says, oh, Mum, that nursing home's fantastic and Marjorie's living there, and you've been a bit lonely. Oh yeah, that's great. I'd like to go to that nursing home. Johnny comes, shows the other side of the cube. Mum, you've really loved the house. It's a great place. And, the food's not so great. Oh yeah, I don't want to go to the nursing home. Now, is that because Mum wants to play, forgotten a name now, one off against the other? No, it's not. It's you present a problem without any ability to abstract reason. You can't turn the cube over in your mind having thought, oh, hang on, well, the food's not so good, but I am a bit lonely at home. I can take the dog, but I don't want to do this. How am I going to solve that problem? If you haven't got abstract reasoning, you can't solve those problems. And every part of the problem needs to be laid out in front of you, literally, in a concrete way, in other words, right there, and then you can start putting this together. So it doesn't mean you can't do it. It's just that it's more difficult. We have to think that through. And lastly, the bit about abstract reasoning, which I think is terribly hard for families and carers, and also particularly hard in hospitals, is that in fact we don't have the abstract idea to look at the emotions of other people. Empathy is more difficult. Nursing staff say, why is he so grumpy? Well, I said, what were you like when you walked in? Well, I was a bit stressed. We'd had 2 arrests and somebody else coming to theatre. Well, were you tense? Were you a bit grumpy? Well, not surprisingly then, the patient responds, and what we call this is an emotional mirror. In other words, the emotion you portray is not able to be processed by that person and say, oh, poor dear, here I am in hospital, and I heard that alarm go, and that doctor was really pretty brutal down the road, and so I've got to be really nice to this nurse. It's no way can someone who's got frontal dysfunction because of Parkinson's disease or because of any other disturbed executive function can empathise to that degree to then respond to the nurse, other than to say, well, why is he or she so angry? And so we talk about these 2 changes to be typical of those with significant frontal dysfunction. So I wanted to take you through this definition because dementia's not easy, but it's actually not as hard as it looks. Because in fact, if there's memory plus one of those thinking domains is abnormal, irrespective of how subtle it is, it might just be difficulty with language, then that in my definition is a dementia. But it might not be in everybody else's words. And if you work in the residential care environment, I've heard people say, that so-and-so doesn't have much of a dementia. But they're in the residential environment because of their dementia. And by definition, in research and in medical language, by definition, that is severe. Because if you have to go into residential care because your memory and thinking is so impaired you can't manage any more in the community safely, then by definition that dementia is severe. I've now lost my... So do those sort of aspects of the symptoms of dementia ring true for those around the room? I'm sure you've sort of had an aha, it's been like that for me. Are there other aspects? That we need to talk about other aspects, so we're going to move on. So I'm not going to talk much about the other parts of the definition, but it has to obviously, you can't, if you've got Down syndrome, for instance, you have to have a change in function before you can have a dementia. You might be impaired because of your Down syndrome, and I use Down syndrome because Down syndrome is an abnormality of the 21st chromosome. People might not know this, but the 21st chromosome, there's 3 of them instead of 2. We've all got 2 chromosomes, and you have each of the 46 chromosomes that we've got apart from XY. I won't go into that. It's male and female stuff. But chromosome 21, there's 3 in Down syndrome. And the very important thing about chromosome 21, we're sort of flying around here a bit, but chromosome 21 is where we replicate amyloid precursor protein. Now think back, short-term memory. Kathy used the term amyloid precursor protein as the precursor protein to beta amyloid. And if you've got Down syndrome, almost invariably the population over the age of 55 to 65 will have Alzheimer's disease. And that's one of the theories around why we think the amyloid story is still relatively strong. So we'll need to, that story. And the point is about this is that I often get asked to see people with Down syndrome. What I have to know is that they've actually changed in function. Because if they're impaired before, and they're still doing the things they always used to do, then they can't have a dementia because they haven't changed their previous level of function. They might be more difficult, and sometimes there are underlying psychiatric conditions associated with Down syndrome. They might become more depressed or more agitated. But when you ask them about dressing and showering and preparing the meals and putting out the table, they don't change. So you've got to have a change from existing pre-morbid function. And that's why the family story is so important. So I'm not going to talk about delirium. But I did want to talk briefly, because this has been done, about pathology. So we're talking about amyloid. So this is my attempt at a simple slide for amyloid. So APP is amyloid precursor protein. Okay? So one way you can process the amyloid precursor protein, which is the good way, with a pair of scissors called gamma, and gamma is the sign that looks like that. And for those who are on this side, oh God, there's nothing. is that one, right? That's gamma secretase. And so for those on this side, you can see what gamma secretase is, yes? Yep, it's that one here, right? So if you cut this protein with gamma secretase, you cut it once and it cuts A beta in half. And if you cut it in half, then you can chew it up. Your little cells called microglial chew it up. So that's the good way to do it. So we want lots of active. Sorry, that's alpha secretase. Did I say gamma? Alpha secretase, sorry, A. All right? If, however, we don't have a lot of alpha secretase and we process it in the other way, we cut it with two pairs of scissors. One called gamma and one called beta secretase. And the studies with beta secretase, that's what it came from, are studies to try and stop the beta secretase from working, because either if you can leave it with one long molecule, so in other words, you block beta secretase and you end up with this connected. If you block that, then this gets connected to the rest of the amyloid precursor protein. If it's that big, you can process it. It just happens when it happens to be this size, which is actually 46 proteins long. It actually has this tendency to stick together, a bit like fat on the top of the kitchen sink when you forget to take the plug out the following morning. Do you know what I mean? Yeah, it's pretty ugly, but that's what it is. And it actually is a form of protein fat that is sitting in the brain, and when it gets accumulated like that, it starts an inflammatory reaction, and that damages the neurons. So does that help with the pathology story? So that's the Yates's sort of simple description of what happens. And we all have amyloid precursor protein. If we didn't have amyloid precursor protein, we would die, because we need amyloid precursor protein. We also need gamma secretase. So the gamma secretase tests and treatments didn't work, because once you knock that off, you ended up with a whole lot of problems with skin cancers, because that secretase was doing something about regulating our understanding of abnormal proteins in the rest of our body. And so then if you didn't regulate that abnormal protein, then skin damaged cells don't get seen, and then they don't get cleared away, because we're all making them. It's just that we have a body that knows that that's going to be a melanoma, and this isn't, so let's clear away that one cell that's got melanoma tendencies. And things like gamma secretase are important for that. But beta secretase we don't think has any other particular useful process yet, so we can block that. And so then we can stop amyloid A beta from forming. Does that make sense? Solve the pathology story? Good. 5 minutes, my God. Go so quickly. So the other story was about time. And this comes back to prognosis and the 20-year story. And so there are two slides here, and these are quite difficult to see right at the back. I don't think anybody at the back is going to be able to see these well. But if you look at the top, your top left-hand corner, we talk about this is abnormality and this is normality. This is normal here, and this is preclinical change, this is mild cognitive impairment, and this is dementia. And the lowest curve is the things that we do now, which is actually look for symptoms of change. So we talk about mild cognitive impairment when there aren't many symptoms, but just a little bit. Okay? And we talk about dementia when someone we magically say that someone's crossed a line. I mean, when I see someone with dementia who say, look, I'm sorry, I think this is a dementia, they're no different walking. They were no different walking in than they are walking out. I mean, what does my word saying, I think this is a dementia, how does that change them right there? And then it hasn't changed anything other than the whole world, because you've just told me I've got dementia, which is a very confronting diagnosis. But ultimately, functionally, they're no different walking in than they were walking out. So if they drove their car to come and see me, and I say, look, I think this is a dementia, do you think I'm going to stop them driving when they go out? No, not really. I mean, certainly not in Ballarat, where you can't drive, you can't go anywhere. But we're going to have to talk about it at some point. But did you see what I mean? I mean, this is a line in the sand. But more importantly, that's when there is change that I can see symptomatically. But in fact, when this is amyloid. So amyloid is accumulating early. And this was the theory. This was a theory suggested in 2011. And it was proven by Colin Masters and their team at Melbourne University in 2013, when they did studies using a PET, which is one of the scans which measures amyloid load in the brain, and they looked at those scans and looked at what happened, and they measured that against clinical signs. And they realised then that if they had someone who was presenting here with clinical signs and a lot of amyloid, they could actually track back and see what had happened. And the amyloid is accumulating somewhere in the vicinity of 19.2 years before we have symptoms. So right now, with an interest in dementia and Alzheimer's disease, I think I'm like the kidney physician, the kidney doctor of about the 1800s. I'll collect your urine, put it over some water, sniff it, and say, I think there's something wrong with your kidneys. By which case, the kidneys were gone. They were completely gone. And we didn't have a biomarker. In 1803 or 4, the physicians didn't have a biomarker for kidneys. We didn't have creatinine or urea or those blood tests that we have now because they didn't know what was going on. So they just looked at the urine and found protein in the urine and said, well, your kidneys aren't going to be, we'll do what we can. I think we're there now in Alzheimer's disease. But at least we know it's going to get better because we're going to find, we can now measure amyloid load in the brain. The challenge is it's no good telling someone they're likely to have Alzheimer's disease in 20 years when we can't do anything about it. But it is going to be important because in fact it's going to be those of us who are at risk, and I talk about that because there's a family, I've got a family history in my family of dementia. Those who have a family history of dementia, when we've got disease-modifying agents, may want to go and have biomarker studies done early, the minute we find our memory is not quite like it should be, and then think about treatments when those treatments become available. And if they do become available, it'll completely change the whole dimension of caring and treating for Alzheimer's disease. And the holy grail of this, and I'm just going to go back one step because I know I'm going to run out of time, is this. And I'll try and explain this slide, but if we can delay the onset of dementia by 20% and delay it by 19.6 months, we'll delay the age-specific incidence rate by 20%, which means by 2050 there'll be 45,000 less cases of dementia in the community. So we often aren't trying to find an absolute cure for dementia, but if we can delay dementia onset by a period of time, then we actually can make a substantial difference to the cost at a community level. Now, it doesn't help the individual who then acquires a dementia. We still have to look after them, but maybe we'll have more resources to look after them, which is what we need. And I think the last thing to mention about sort of, oops, I'm going the wrong way, about this is just to be clear that what Kathy was saying was absolutely right. There's some pictures of funny brains. But we do know that there are risk factors for Alzheimer's disease that are in the environment. So if you've got a family history of Alzheimer's disease, we're not going to say you won't get Alzheimer's disease because we can't be sure about that, but you can minimise your risks by managing some pretty simple things. And this is the weighted proportion of risk. So 2% of the risk might come from poorly managed diabetes, midlife obesity. It's really important. We can't stop taking our medications for hypertension, for instance, at 65. That's exactly when we should be managing our hypertension the best, because that's where the risk comes. Physical inactivity and cognitive inactivity are also key problems. And just to show that we can make a difference, this is a study, a prevalent study, which has just been released. It was released in 2013, not just, well, maybe a couple of years. But here you can see the red lines are lower than the blue lines. This was exactly the same study repeated in two populations, one from 1991 and one from 2011. And the prevalence of dementia was less in the 2011 population than the 1991 population. So actually prevalence is the number of people with the condition in a community for a set number of people. And that reflects good blood pressure management and good stroke management. That's what we think. So we can change dementia prevalence in the community, but we've got to actually do the things that we know we need to do. So I think this is a very positive, that's a very, very positive story about physical exercise, reduced smoking, good blood pressure management, physical exercise and social engagement, all the key components about dementia care. Right, 5 minutes is probably well and truly gone. I did, if I could, mention just one thing, which was the Dementia Care in Hospitals program. How many people might use the Queen Elizabeth Hospital as their main hospital? A couple? I'm hoping that, well, they've gone live now, so if you go into the Queen Elizabeth Hospital now and you're over the age of 65, you'll have a screening test for cognitive impairment. Very simple one, just 10 questions. And if that's abnormal, this alert, with your permission, will go over the bedside. But that's only going over the bedside because the hospital and the staff have been trained to do some very important things. Introduce themselves. How many people? Staff just don't do that, but they will do that now. They'll make sure they've got eye contact at all times. Why? What's that attentional thing, that planning? And Kath and Kim had it right. Look at me. It's true. You know, the English language said, you know, their eyes glazed over. We know. I know when my kids aren't, and I've got adolescents now, I know when they're not listening to me because their eyes glaze over and I always want them to look at me. So I've got their attention. Remain calm and talk in a matter-of-fact way. This is that emotional mirror stuff. So this alert allows staff time to get themselves centred. So they don't go rushing into a patient, all in a fluster. They spend some time thinking about it first. Involve carers. This is what's expected. So if you see this alert over the bed and you're not being involved, remind the staff that they've engaged in this program and they've committed to it. Keep sentences short and simple. Focus on one instruction at a time. Give time for responses. That's that slow thinking process. And we train not only the nursing and medical staff, more importantly, we train the ward clerks, we train the lady who comes to give the cups of tea, and we train the porters. Because there's nothing more frustrating for someone who's trying to get that answer out when the lady comes to the cup. Like a cup of tea? Milk with that? Oh, was it coffee? Sugar? Yes. Okay, so what are you going to get? Very difficult to know. So what we train the ladies, and well, mostly they are ladies, but people who are providing at least hydration in hospitals, is they need to give time for a response. So in other words, would you like a cup of tea? Now this alert's over the bed, what am I going to do? I'm going to wait for a bit of time. Did you hear me? Mary, I just want to know if you need a cup of tea. No thanks. Oh, okay. Would you like coffee? Yeah. Because then they'll maintain hydration, and hydration's a risk for delirium. So repeat to yourself. So if you get repeated at, just say, look, I already heard you, because sometimes we'll use this alert when people are just really sick and they've got a delirium, and sometimes that gets better. And so then they might get better, and then they don't need to be repeated to. And don't give too many choices. So expectant compliance is something that is very helpful to use, which is where you say not, would you like to go to the toilet, but it's time to go to the toilet. That's expectant compliance. Great thing to do. I don't know whether you ever had an opportunity to do any training, but I did it once with a whole group of health staff, and as they walked in after lunch, I said, take your shoes off. Just take your shoes off. Take your shoes off. Thanks very much. Take your shoes off. Half of the audience took their shoes off. They said, why do you want us to take the shoes off? I said, just wanted to see what you'd do. And that's expectant compliance. So it'll work about 50% of the time. So if you're at the Queen Elizabeth Centre, Queen Elizabeth Hospital, this alert will be over the bedside for staff, and this is the Dementia Care in Hospitals program, which is here. And I'm going to stop next. Oops. And what we're trying to do is avoid this. So what we do know is patients with dementia who are in hospitals have about 70% greater chance of having a urinary tract infection, and almost 3 times the chance of having urinary tract infection if they're on a surgical ward that's matched for their comorbidity. So matched for all the other conditions they've got, matched for their age. If we take populations and say this population is a population with dementia in hospitals and this is a population without dementia in hospitals, then for some reason we don't understand why, you're more likely to get a urinary tract infection. We understood delirium. Delirium is that acute confusion that happens when someone gets sick, but not the rest. So, I've mentioned the hospital stuff. Someone asked about, let me think, sundowning was the last one, something I asked about. I like to think about sundowning in relation to the concept that the brain is a simple organ. And it really only tells us who we are, where we are, and what we're going to do next. And if you think about that, if you ever didn't know who you were, what would you do? You'd go looking for why or who you are. If you didn't know what you were going to do next, or where you were, what do you go do? You go and find out where you are. Our brain does not like us to not be sure about some fundamentals. That's who we are, where we are, and most of the time what we're going to do next, except when you go to a tropical island for a holiday and you actually allow your brain to relax. And you actually buy that. We pay good money to allow our brain to switch off in a safe environment. And so if you think about it and you've got a memory problem, what you have to be doing is rebooting your system on a regular basis. And this is pretty politically difficult. But if those of you who have looked after grandchildren or looked after children, if you ask parents of young kids, like about the 1 to, say, 3-year-olds, when arsenic hour is, it's about 4 o'clock or 5. It's usually just before meals. And if you don't get the meal laid out and you don't stick to the routine at that particular time, Dad comes home from work and razzes the kids up just the moment, you get eaten alive. I was always told, come back at a useful time. Which was... and I think that in children, they wake up knowing who mum and dad's going to be, and these are brains that are developing their cognitive processing, and they reboot, but at a certain point they get tired, and if you don't keep the routine, then they have difficulty just working out what's going on. And I think if you're living with dementia, you try and reboot your system on a regular basis, even subconsciously, to say, oh yeah, that's right, I'm at this silly talk with some guy at the front. Who is he? Oh, yeah, that's right. And you're doing this time and time again. And I think it's cognitively fatiguing. I think at some point towards the end of the day, you can no longer either boot the system or you're just too tired to boot the system. And then the brain will not live in a vacuum. So if the brain doesn't know who it is or where it is, it will make that information for it, because otherwise it's anxiety provoking, because we don't like to not know who we are, where we are. And then we might end up with behaviours or called behaviours that look to us to be unusual. But in fact, if in fact that person has normally collected children in the afternoon or prepared a meal for a husband to return home at that particular time, maybe that's what they're doing. But it looks odd to us. You've had your tea. What are you doing making tea now? Or, no, you don't have to go and pick anybody up. Oh, yes, I do. I've got to go and... And I think some of that sundowning is because of that cognitive fatigue and then vacuum filling. So to understand what the behaviour, which we call a behaviour, I hate the language, we've got terrible language for this, but I think what happens is a person acts, that none of us choose to be disruptive. I don't believe anybody with dementia chooses to be disruptive. I think they're looking for something to be secure. And so what happens is when they're no longer able to be sure about their environment, they're going to look to find something that ensures them or provides them with that cue. Often it's a family member, what I call a cognitive anchor, terribly important in hospitals, because nursing staff will tell me the same thing. Late afternoon is when patients are finding it more difficult to manage in this toxic environment we call a hospital for patients with cognitive impairment. And I think that's because they're fatigued. And they often look for a cognitive anchor at that time, and that's a family member. So I think that's my pet theory for sundowning. Have I got any evidence? No. And as I said, this LinkedIn have got an Alzheimer's blog group, and there's been a really long discussion over the last 2 weeks about sundowning, which I thought was very interesting. And there was also a discussion about, is it okay to talk about dementia in the setting of behaviour that you might see in children? It's a very, very difficult environment to be in. But I found it's very helpful for families to try and understand something of what it might be like. But I don't want people to equate getting old with childhood, because it's not just a reverse of things. So you've got huge wisdom. And I think the important thing is to understand that an older person is using all their wisdom. But it may be that they're using that wisdom having interpreted their environment in a way that we don't interpret it. So their action seems unusual to us, but we just don't understand the process by which they've come to the conclusion that this is what they need to do. And so it's seen as challenging behaviour or disruptive behaviour or wandering. So it's my cup of tea. So I think we've talked about, I can't address aged care facilities because I think that's too big. The scanning question is partly about FDG. So we've got a number of different scans now. MRI is a very useful test. It's a much more detailed test than a CT scan. I'd still ask my GPs to do a CT scan, because if there's an obvious problem like a tumour in the brain or bleeding, the CT scan will pick that up very easily. But if there are subtle changes, sometimes that's not picked up on a CT scan, and I can see that on an MRI. That's particularly for vascular change, so mini strokes. if in fact there is, we can now use serial MRIs. In other words, those don't come out of a box, cardboard box. I love that, as serial MRIs. I was thinking, and doing them in frequency, following them 6 months apart. You can look for changes in the hippocampus, which is the part of the brain that is important for memory performance. The FDG PET is just an ordinary glucose PET. It just looks, that's a PET is another form of CT+. It uses radioactive particles to measure activity in the brain. And so you can look for brain activity in certain ways, and you can look for abnormalities. And in Lewy body dementia, it's very important, or very useful, because if there is poor activity in the brain posteriorly at the back of the brain, which is where the occipital area is, that's the vision, then in fact it's often consistent with Lewy body dementia. And for those who know much, had an experience with Lewy body dementia, hallucinations are a very common presentation of Lewy body dementia, along with the change in mobility. And that's because the brain's visual area is not working well, so it's filling in some gaps. The other thing is then about amyloid PET. And so this is using a radioactive tracer that actually attaches to beta amyloid, those bits of fat that were going to be on top of the sink if you left it to go cold overnight. And so then you can look at the amount of amyloid load, and Colin Masters' work was using that particular tracer to see how much amyloid was in brains. And this is the story where we know that people are accumulating amyloid. And so it begs the question now about whether we talk about two things: amyloid, Alzheimer's disease, which means that there's amyloid accumulating in the brain plus some other biomarkers, no dementia, and then Alzheimer's dementia, which is when it has progressed to the point where there is a change to memory and thinking. And so we are now in this rather difficult position now where you might hear people talk about Alzheimer's disease and Alzheimer's dementia almost as if they're two different things. Well, they're not really. It's just that it's on the assumption that amyloid is the key problem. It's just that there's amyloid present here, but there's no functional change. And now there's enough amyloid there, but then now there's functional change. Do you see how we can see this could be a continuum of pathology, but with two different things? One is no abnormality and one an abnormality. Went to see neurologists. Look, I don't think there's a great deal. I'm a geriatrician, so I'll spruik my craft. No, that's not true. In all reality, if you went to the UK, if you had a talk from someone about dementia, you'd be hearing it from a psychogeriatrician, an aged care psychiatrist. If you go to the States, you're going to hear it from a neurologist. If you come to Australia, you're going to hear it from any of us, because neurologists, geriatricians and old age psychiatrists are all interested in this space. So is there a particular reason to see a neurologist? Not really. It seems that Kathy Boundy and Karen and her team at the Queen Elizabeth Centre have got a fantastic unit. And so they've got a very keen interest, but I've got neurology colleagues who don't want to go anywhere near dementia, and they just send it to me in my clinic. So it depends really on the referral patterns. So what I implore you to do, if you're going to see a specialist, make sure you're seeing a specialist who has an interest in the area, not just any specialist, because not all of us can take up every part of an interest in a whole field. The MMSE score, the very first question I'm going to finish with, because someone asked what is the MMSE. The MMSE stands for the Mini Mental State Examination, and it's a very well and widely used simple screening test for memory and thinking disorders, because it asks questions about where you live and what seasons it is, and then it asks a very simple memory question. It says, I want you to know three things: apple, table, penny, and it can be a whole lot of other ones. And then you get asked to spell the word world backwards, or count backwards, start with 100, subtract 7 from 100, and keep subtracting 7 from your answer. You can all do that now. How many what were those three words I wanted you to remember? Yeah. So and then there's a gap, and then you ask those things. It's very simple, and then there's a number of other questions that go with it, including writing. In my hospital, we use the Mini Mental State Examination form as our standard screening test for every person over the age of 65, and we add to that drawing a clock face. Now, the clock face drawing is very important because it picks up delirium, which I haven't talked about today because we were talking about dementia, but it's the acute confusion that often happens where someone with dementia goes into hospital and everybody says, look, they're a hell of a lot worse now they've been in hospital. Why? So the MMSE got a bit of bad press for a few years, so there's a lot of other scales that are being used because there was a question about it being patented and then having to pay a licence to use the MMSE. But the Australian government's resolved that now, and so the standardised MMSE, which is exactly the MMSE, but it was just someone who's done it in a standardised way, is now freely available to every health practitioner in Australia, and that is that's been made clear by the Australian government. So nobody should fear using the standardised MMSE, and if you go to a really weird site called the Independent Hospital Pricing Authority, IHPA, that is where you're going to find the standardised MMSE. Why it is at the Hospital Independent Pricing Authority, I've got no idea, but it's there and you can use it freely as a health practitioner. Publication and things, you still need to get some approvals, but that's okay. I think that probably does cover quite a lot of what I was asked. I hope that's been helpful to you, and I'll thank you very much.